So I'm just going to talk to you a little bit about what's been happening in the space of diagnostics. I don't have any slides for what's been happening in treatment, but I can talk briefly to it. So I think you will all know the numbers, which is, this is data from the National Ovarian Cancer audit that's been running since 2024. And we put data in public domain that is accessible and a report that is patient-facing. And that gives us the national picture in terms of what the outcomes for women with ovarian cancer are, both at the national level but also at the local level. So there's quite a lot of, if you're slightly geeky, then you can have hours of fun looking at data in across the country in terms of what hospitals are doing and what treatment rates are like, for instance. And we think we would produce more interesting data in the years to come. So I guess for me, this is what's called the Kaplan-Meier survival curve, and it really reflects what happens to 100 women if they go down two completely different paths. The black line there is what happens to women if they're referred from their GP or they have an elective process in some way, and their likelihood of survival and the number of women who will be alive at the end of, say, a year, which will be around 80%, marked there. And this, the red line reflects, I'll see my list.
I don't think it works.
Right?
I don't think it works.
So, and the red line reflects the proportion of women who will be alive if they're diagnosed after an emergency admission. And you can see that at 12 months, at this time point, there's about 50% of women who will be alive at the end of 12 months. So it's very clear that one of the major reasons why we don't do quite as well in the UK. I think it's an international problem, but it's a particularly relevant problem in the UK, where we have a challenge with getting people diagnosed at a point in time when they are fit, when they are well, and they are able to have treatment. And the problem when this is the starting point is that it's very hard for this overall, if you combine the two, it always looks like we're doing badly. But actually, we're not looking badly. If you are one of those people who managed to get to Mr. Balega and his team, actually you do pretty well. The problem is that if for those women who end up being diagnosed in uncomfortable situations, then it's quite hard to overcome that detriment of being quite poorly when you were diagnosed. I mean, it does still happen, so it's certainly not something that's not possible, but it is, it's harder. And at a national level, if this is your starting point, it's very hard to lift the whole national picture because 40% of your women are coming down this road. Does that make sense? So it's very hard for the overall numbers to look good, and therefore we almost always don't look them here. So our problem really then is that if we want to overall our numbers to get better, we do need to focus on what happens surgically, and there are several issues here, and Mr. Balega has outlined some of them. But actually, we also need to make sure that people get to the starting point when you fire the gun, that you fire the gun at the best possible state of play. So we think there's issues around women being aware of their symptoms, which is understandable because these are quite vague symptoms. Our challenges in accessing primary care, and Amina and I are good friends and close collaborators, so we're both on the same page with this. Issues with primary care colleagues recognizing that the woman in front of them may have ovarian cancer, and that's work that Mr. Balega has done lots of work on locally, I've done lots of work on nationally, but it's understandable. You know, this is a rare cancer. They maybe see this once every few years. There's a lot of things that are vague and non-specific.
So picking up, and a woman will need to go and see her GP at least 3 times before the issue of ovarian cancer is considered. So how do we kind of build it into the system where there's easier suspicion of ovarian cancer raised? And then there's of course things like secondary care delays. So one of the things we looked at was to see what the yes, when a woman comes in with emergency admission, such as had an emergency admission, what's that critical time where you have to intervene? And this is a busy slide, but essentially this is a slide that you've seen before, where I've shown you how broad the difference in survival is. And even after you adjust for the fact that you adjust for things like did both groups of people have similar groups of women with regards to age or to frailty or to other things that could be wrong with them, you still have a difference. And it looks like most of the problems happen in the first 3 months. So if within the first 3 months after a diagnosis, you're well enough to have treatment, then actually things will work out okay. But the big steep fall happens within the first 3 months. So we're doing a piece of work to try and see how we can rescue people who come to secondary care but maybe are quite poorly and then really need support in terms of nutritional build-ups, in terms of expediting, making people have biopsies quicker, making people have treatments quicker. So that's a piece of work that we're trying to do nationally, and we'll see. And if you look, again, another piece of data, but essentially, if you look carefully at the profile of women who've been diagnosed with ovarian cancer, and who are these women who have emergency admissions, and this is a graph which looks at lots of risk factors. So, is it because you're older? Is it because you're younger? Is it because you're more deprived? Is it because you're ethnically diverse? Is it because those women were just not terribly fit? And it looks like the women who tend to be diagnosed, I mean this is a broad statement, who have emergency admissions, they tend to have slightly more deprived backgrounds, and that reflects, I think, broader health systems not supporting those women. Ethnicity is not really a huge factor, but it's very small numbers, so it's hard to know whether it's real or not. But what's very clear is that if you're unfit, so you have other things going wrong with you, lots of things like hypertension, diabetes, chest problems, kidney problems, the more problems you have, the more likely you are to have a mixed diagnosis of ovarian cancer, because presumably everybody is concentrating on everything else but the possibility of ovarian cancer being a thing. So this is quite an important thing. So how can we set up systems in a way that we reach out to the people who are maybe not as fit, to try, and I use fitness in a sort of medical way, which means you have other things wrong with you, to try and make them get diagnosed early, and that's certainly stuff that we're doing. And why is this important? Well, this is a relatively, this paper of ours really got a lot of attention. It was featured in The Guardian and in The Telegraph, and I was quite pleased about it actually. But basically what it showed is that if you pick up women who have symptoms and you get them through to hospital, what you end up with is you have women who tend to be fitter to have treatment. You tend to have women who have less advanced stage, and even the women who have stage 3 or stage 4 cancer, they tend to have less cancer than women who had emergency admissions. So there's real mileage in trying to pick women up in the community with symptom awareness and primary care testing, because you may not, you'll get people to a point where they'll be diagnosed when they can have treatment, and that's a really, really useful thing to do. So fundamentally, the mood music, I think, is still consistent with, we haven't got a better test than symptoms at the moment. There's lots of research happening in terms of trying to find ovarian cancer before it gets to this point, but that's still, I think, we haven't got to the point where this can be used clinically in any way, but there's interesting stuff going on. At the moment, testing people and rapidly testing people and referring people is the best thing we've got right now to pick up women with ovarian cancer when the cancer is certainly at a less, not necessarily advanced in stage, but is less amount of cancer. When Mr. Bulega was presenting, he presented to you all of the places where the cancer could spread, and it would appear that if you test on the basis of symptoms that you end up with cancer that has spread a bit less to the top of the tummy, which is a good thing because it means that you have lesser surgery and you have less cancer, basically. The burden of cancer is less. So that's a good thing. So what's new in this space is that NICE recommendations have changed. So this year in April, NICE have come out and said that for older women, so women basically over the age of 50, that CA125, which is the first test which is used by GPs, we've previously always used a blanket threshold. A threshold is a level. When you do a blood test, there's what's high and what's low, and normally there's a level, and that's called the threshold level. And thresholds set really to try and make sure that we pick up the people who may have cancer, but don't pick up too many people who don't have cancer. So the threshold used to be set at 35 units internationally, but now the UK, NICE have, on the basis of quite good data actually, have said that we need to be dropping the thresholds for women who are older, because there's a group of women who, if we used a lower threshold, and I'm making this list, but if we'd used a different threshold, then we may have picked up more women with ovarian cancer. And this is really exciting because it's a relatively simple thing to do, but we now have the big piece around how do we get this into laboratories so that, because obviously the average GP, they can't remember it for each time. It needs to be in the lab report, so it flags up to say this is the age-related thresholds. Because for most people, they would just be scanning and pick up on where it's red rather than black, because they really don't have the time to be looking at each indicator for each patient that they have. So how does this then get into laboratories so this can be flagged up? And then for the GPs and the patients, because this should come on an NHS app, for women to advocate for themselves, to say, well, I'm supposed to be tested when I'm supposed to be further tested when the CA125 is 31 rather than 35 units per minute. So this is probably the biggest thing that's changed recently. And the nice thing, the flip side of that, which also I think is quite important, is that it's very clear that for younger women, and I would argue even below the age of 50 rather than from the age of 39, that CA125 on its own is not accurate enough for this age group, and that actually they ought to be having direct access to ultrasound. And certainly data that we've done, published in BMJ this year, shows that it's very clear that if you, so ultrasound is one of my bugbears because it tends to be very poorly done. So you end up with a report that is not terribly helpful because the quality of scans varies. We have a 15% shortage of sonographers in this country. And so because ultrasound isn't standardized and done to the highest level possible, it's often not as helpful as it could be. And certainly data that we published earlier this year shows that if you use a specific model called the IOTA-ADNEX model, And that model combines CA125 as well as things that people can look at in the ultrasound. It actually is the most accurate test you have for ovarian cancer and picks up more than 9 out of 10. Actually, it's 96% out of 100. So it practically picks up every woman with ovarian cancer, whether they're early stage or advanced stage. And that means that if we can have high quality standardized ultrasound available using this model, which as I said uses the exact value of CA125 as well as how the lump looks like, then we could pick up women with ovarian cancer. But that comes back to us having, and this ultrasound wasn't performed by experts, it was actually performed by sonographers who'd received training in quality assurance. So that's the other thing that we're trying very much to do, and I'm really pleased that multiple cancer alliances, that's the kind of people who run cancer services in the country, are now rolling it out. So if we're able to roll it out, so East of England, the West Midlands, the East of Midlands, the South, I can't remember, but several alliances are rolling it out, and that's going to be a really positive thing. There's also a pilot that's starting in around Southend sometime later this year to see how that will work in primary care, and I think that again will be really, really helpful. Now this is a very technical slide, but essentially what it means is that these are in the model, which is basically a model, it's just a formula. You put in how old the person is, you put in what the CA125 is, and then you put in some stuff that you can see on the ultrasound, and then it gives you percentage chances of whether the woman's got an innocent lump, what the risk of cancer is, what the risk of her having early stage cancer is, and what the risk of her having a cancer that's spread from somewhere else is. So this has been quite useful, and certainly the good thing is when we've introduced it in hospital, we've been using this now for a few years, and it's really meant that we're able to discharge people quickly, because we're able to say, look, you don't have ovarian cancer, you're okay, and we've been able to discharge 40% of women on the same day that they presented to hospital, because we can say to them, actually, you don't have ovarian cancer. And that's a positive thing, that's a really positive thing in my view. So, in terms of how we make this system better, we need to facilitate symptom awareness and health literacy and women advocating for myself. My youngest is 17-year-old, and it's astonishing how I teach her what to say when she has to engage with the GP. Myself, this is what we say, okay? We say X, Y, Z, and if you say this, and I know what to say. But I'm worried that people who don't know what to say will not say the right things, and it's quite a sad state of play wherein hopefully this will improve over time. One remains in hope. I think age-adjusted thresholds for CA125 have just come out, and that needs to percolate in the system. I think standardized ultrasound is a really important thing, and colleagues and I are pushing for this. We have very interesting AI solutions for this, which colleagues of ours in Belgium, but also in one of the Nordic countries, I think this is, and the Chinese, I think there's some really good papers on that. And I'm very optimistic that we'll get to a point where we'll have AI to support sonographers make better reports, and that I think is one of the real positives of AI in healthcare that will come. I think we need to improve how colleagues of ours in hospitals see women with ovarian cancer, because we know we can treat this well. We have excellent clinical teams. But that's often not seen in the context of a busy hospital, and women with ovarian cancer might not necessarily be triaged to the right teams, or because it's considered that they've got lots of cancer and it's everywhere, they can't be treated, and actually they can be treated quite well. So we need to do a piece of work around supporting our colleagues in hospital understand the uniqueness of ovarian cancer. And with that, I'll finish my presentation. Those are the things, I'll just briefly talk about treatments. So those are the things that are changing in diagnostics. In treatment, I really think, I think over the next 5-10 years we'll see some really interesting things come. We'll see AI in ultrasound, and I think that would be amazing. We'll see some really good pieces of work around how we pick up ovarian cancer before it's manifested in symptoms, and I think that's in research space, and I'm a great optimist. I believe in these things. I think we will see better treatments. So last year or 2 years ago, we had the ASCO presentation on mirvetuximab, which is the first drug we've had in platinum resistance. So women initially have platinum chemotherapy, then unfortunately over time they may not respond as well to platinum. So 2 years ago we had the first drug that actually improved survival in women who were not responding that well to platinum. That was the first major breakthrough we've had in this space for, I don't know, since I was training to be a gynae cancer surgeon. So that's been really amazing. That's a 4-month improvement in overall survival, which for that individual person really matters. And there's several trials being launched now on this class of drug called antibody drug conjugate, where we have clever drugs that pick up on specific signals that the tumor has, and these are chemotherapy drugs, or drugs that are killer drugs, conjugated, bound to antibodies that recognize specific signals in a tumor, so it's quite clever. So these drugs target specific groups of people. So I think going forward, we'll see a lot more biopsies done in women who've recurred. We'll see a lot. We'll be trying to persuade people to have more biopsies when people have recurred, or we'll be doing more tests to find out whether these cancers are showing these particular signals. At the moment, we're working on the signals that are seen when people first present. That may or may not continue, we'll see. And then I think we'll move to a more knowledgeable way of treating women, where we figure out exactly what signals that cancer has and try and give people drugs for that. I think surgery will become more prominent because there's all the surgery that we do when women are first diagnosed. I think that if we have newer drugs that can move people, that can swing out the time taken for when the cancer comes back, we may be at a point where our colleagues, Mr. Balega and team, are operating more on women for recurrence. I think that space will happen. So I think these are exciting times. Well, it's easy for me to say because I'm the academic, you're the people with the disease, so maybe exciting is not the right word, but I do think there's huge progress that will be happening in the next few years. Okay, thank you.